The next topic is psoriasis in children and how to manage them, the management strategies, by Dr. Maitreyee Panda, a specialist in pediatric dermatology from the Department of Dermatology at IMS and some hospital, Bhubaneshwar.
Good afternoon, everyone, and thank you, Pulsan Derma and Sandeepan sir, for giving me this huge opportunity. Since my PG days, it was always a dream to be a pediatric dermatologist. I started my career watching sir in ISPD conferences, and that is when I decided that I should go ahead with this particular subject of pediatric dermatology. So thank you, sir, for being my mentor. And coming to my topic today is on pediatric psoriasis. I have deliberately omitted the management strategies because I'll be focusing few on the clinical aspects as well as on the approach to diagnosis and some interesting cases and a brief about the management. So pediatric psoriasis is a chronic immune-mediated skin disorder that affects the skin of the children and the adolescent, and they usually present as very well-defined indurated scaly erythematous plaques. The nails, the scalp, the palms and soles and mucosal involvement are commonly seen with pediatric psoriasis. However, the prevalence of psoriatic arthritis is about 1 to 10% and seen in the age group of 9 to 12 years. So a brief insight into pediatric psoriasis, 20 to 35% of the patients with psoriasis have their disease onset before the age of 20 years. And of the pediatric population, in total, 1 to 3% are affected with psoriasis, and they have a strong genetic background with a HLA-CW6 positivity. The age of onset is mostly from 6 to 9 years, and there is also a second peak in the teenage beyond 15 years, and the infants are rarely affected. The plaque and the gutted psoriasis types are the most common clinical morphological types. So the clinical presentation follows the plaque psoriasis, which is the most common type. Then we have the gutted, the inverse psoriasis, pustular psoriasis, and the napkin psoriasis. So this particular napkin psoriasis is where we see in the infants and children below the age of 2 years. So how is it different from adult psoriasis? What we usually see is the sites. The psoriasis in children is more commonly involving the face, the eyelids, the scalp, or intraretinal skin, as compared to the adults. The plaques are usually thinner and smaller. They are less prominent scaling and more pruritic. And the erythema is less prominent. Often the plaques appear more of confusing. That is why it is more confused sometimes with lichen planus, because the plaques appear very violaceous and hyperpigmented rather than the thick silvery white scales which we have in our book description. And the infant's involvement mostly in the diaper area can be the initial manifestation. And what we rarely find in pediatric psoriasis is the erythroderma, arthropathy, and pustular lesions. So we often see it in adult patients. Psoriatic arthropathy and pustular psoriasis is something which we see in our regular patients of psoriasis. However, in pediatric patients, we usually don't see this part of erythroderma and arthropathy associated. So few of the pictures of plaque psoriasis and gutted morphology, the smaller raindrop type of smaller papules appearing in crops, they are known as the gutted psoriasis, and the larger well-defined plaques, much less erythematous and much less scaly, that is present on the trunk, is the plaque psoriasis. So this is the typical napkin psoriasis. Most commonly it is confused with candidal diaper dermatitis, and when we see and examine the patient carefully, apart from the diaper area, the lesions which are involved, the scalp, the face and the trunk, then is where the diagnosis makes us easier. So whenever the patient presents in the diaper area only, it is not necessary that you don't have to examine the whole body, because diaper dermatitis can be, psoriasis can be a manifestation which is usually termed as napkin psoriasis. So this is a photo of palmar plantar psoriasis. I have taken it from sir, and the nail involvement is also there, very much evident in this patient. So palm soles involvement and the nail involvement are actually considered poor prognostic indicators in pediatric psoriasis. So what are the triggers? So what history you should ask is a recent history of any URTIs, any trauma, like patient, the kids, they usually play all physical activities that can lead to a trigger of Kibner phenomena. Then any stress, very associated these days, metabolic syndrome, The drugs like withdrawal of topical or oral steroids, and very commonly used is NSAIDs and antimalarials, which can also lead to a trigger of psoriasis. So some more important points like postular psoriasis is rarely seen. It's only about 1 to 3% of the cases. And precipitating factors I have already discussed. One important here is the H1N1 influenza vaccination that can again lead to a trigger of psoriasis. And the gutted psoriasis may be precipitated by Malassezia candida, the retrovirus infection, the streptococcal and the staphylococcal infection, and again importantly you have to look for the perianal dermatitis. And how does the Indian children differ from Western countries? So you have to see that those patients have lower frequency of gutted lesions and more frequent involvement of the soles, that is plantar, probably of the fact that Indian patients are more barefooted, so more of Keebner phenomena in the plantar aspect, and lower incidence of familial occurrence. And we do see a lot of follicular lesions which gets confused with eczema. So coming to childhood pustular psoriasis, it is a rare entity more commonly seen in boys. Typically the pustules appear de novo or on the pre-existing psoriatic plaques. There may be a sheets of erythema studded with pustules. And the common type which we usually see is the generalized von Jumbo's type. The uncommon types are the annular and mixed forms. And these days, recently, there's been a lot of hype around IL-36 and CARD14 mutations, which has led to the description of papilloscomas disorders, which typically mimics a psoriasis in since childhood, not responsive to the usual treatment which we give for psoriasis patients. So this is a typical pustular psoriasis patient having the nail involvement, because nails, pustular psoriasis, and the joints, that is almost like a triad which we see, although rare in pediatric age group. And this was again one patient of pustular psoriasis going into erythroderma, and finally she recovered properly. This was a patient of West Bengal only. And then we had to give her proper treatment, and the entire erythroderma and pustular episode subsided and she responded well. This was a patient of erythrodermic psoriasis, almost like in the child is around 2 years old, and extensive involvement, more than 80% of the body surface area. So this is how erythrodermic psoriasis presents, and the problem with them is the metabolic imbalance associated, and also there is hypothermia and nutritional, subsequently there is some nutritional dermatosis associated. So definitely we need to treat these patients on a priority basis. So briefly into pathogenesis, a genetic predisposition of HLA-CW6. There is an immune dysregulation of T helper 17 and IL-23 pathway, and a Keebner phenomena with the skin trauma triggers the psoriatic lesions. So coming briefly into the differential diagnosis, in case of plaque psoriasis, we see atopic dermatitis or some form of eczemas, nummular eczemas and follicular eczemas, which can be a mimicker of plaque psoriasis. We often get confused with seborrheic dermatitis and pityriasis rosea. And another very confusing entity is the pityriasis rubra pilaris. So these are the clinical differentials. And for the napkin area, we have irritant or allergic contact dermatitis, the candidal diaper dermatitis, and nutritional deficiencies like zinc deficiency and biotinase deficiency, which usually present in the groin area and the napkin and the perianal areas. Now coming to the comorbidities, we have very commonly association of metabolic syndrome in these days. The obesity, type 2 diabetes mellitus, dyslipidemia, hypertension, and non-alcoholic fatty liver disease. This is almost like present associated with many of the autoinflammatory and autoimmune diseases, and that also holds true for psoriasis also in the pediatric age group. And also the psoriatic arthritis, the prevalence is about 1 to 10%, and in contrast to adults, 80% of the children develop arthritis 2 to 3 years prior to the skin finding. And this, usually the first peak is in the 2nd to 3rd year, and it mirrors the juvenile idiopathic arthritis. And the problem in this condition is the second peak appears presenting as spondyloarthritis or the axial disease, which is actually a debilitating and a very morbid condition. So we need to treat these patients in a priority. And uveitis has been reported in almost like 25% of the patients with psoriatic arthritis. Thus, routine ophthalmological examinations and screening is warranted in patients of psoriatic arthritis. So this is a particular obese child of metabolic syndrome having the palm sole involvement, And also this patient, there was extensive erythrodermic psoriasis, but this child was severely dyslipidemic, and there was also associated some other metabolic abnormalities, and the presentation was erythrodermic psoriasis. Coming to the diagnosis, very briefly, as clinicians, from dermatologist point of view, it is almost like a clinical diagnosis. However, we do go for biopsies in very confusing cases. And the importance of PASI, that is the severity assessment, is based on the management, because once we categorize the patients into mild, moderate, and severe, based on the PASI scoring, we can categorize the patient and treat accordingly. And a simple bedside test that is very useful for the postgraduates also, they can regularly practice is Grattage test. We gently scrap the lesions and we see the accentuation of those silvery scales, and then we see a thin white adherent membrane known as the Berkeley's membrane. And once the membrane is removed, we see pinpoint or punctate bleeding points. That is known as the positive auspice sign. So this is oftenly seen with psoriasis patient both in pediatric as well as adults. So we do maneuver this Grattage test in our day-to-day practice to simply diagnose or differentiate between conditions which closely mimics a psoriasis. Some challenges in the pediatric psoriasis treatment. We have limited FDA-approved treatments for children, and the impact of treatment also has on the growth and development of the child, because what we do is dermatologist is use of some some immunomodulators and immunosuppressive drugs, so that has a strong impact also on the vaccination status. Further challenges include no international standardized guidelines. Until recently, just 1 year back, American guidelines have come up, but again, that is not very evident for the pediatric age group. And association with the comorbidities, which I've already discussed, there is a definite depression and anxiety component in all pediatric psoriasis patients, a significant psychological impact and reduced quality of life, and when to decide whether to go for a topical treatment or a decision to start a systemic therapy, and how long to give, what are the safety concerns. So these are the challenging situations, how to proceed in a patient of pediatric psoriasis. So this I am in the SIG, the Pediatric Dermatology from the IDBL Association. So we came with the algorithm of childhood psoriasis, which was published recently. And there the disease severity of mild, moderate to severe has been formulated, where the topical therapy is for only milder cases of psoriasis where the body surface area is less than 10%, the PASI or the psoriasis severity index less than 10, and the dermatological life quality index less than 10%. So in that conditions, in those group of patients, we usually go for topical therapies. So what are the topical treatments available? The first line, every patient should be advised a moisturizer and emollient. It may be a bland emollient, even coconut oil will be an excellent emollient. However, you can also go for paraffin-based and ceramide-based moisturizers. And for the thick hypokeratotic areas, you can introduce urea and salicylic acid for very short periods, especially the palm, soles and other areas which are very resistant to topical emollients. Then the first line of treatment is always corticosteroids, mild to moderate cases. It can range from the mometasone group or further down the steroid potency, but do not increase the potency until and unless it is the hand and palms and soles involved. Then other molecules like vitamin D analogs, calcipotriene and calcipotriol, they have proven their safety in pediatric psoriasis. Some topical calcineurin inhibitors like tacrolimus and pimecrolimus, both are very efficacious in atopic dermatitis and psoriasis involving the face and the sensitive areas of the skin. And some other older molecules like anthralin and coal tar. I would agree that many senior dermatologists sitting here, they have tried with these molecules and they have the response must be very encouraging. However, with the safety concerns and the irritation qualities of this anthralin and coal tar, in today's date, we do not usually prefer these molecules. And newer molecules in the block are tapinarof and tofacitinib, which we are using in day-to-day practice. So this was the recommendation for management of childhood psoriasis, where corticosteroids, vitamin D analogs, the calcineurin inhibitors are all trial tested with a higher level of evidence, and the strength of recommendation is higher up the ladder. So we definitely can go for these molecules. And coal tar and anthralin has to be decided whether to give or not. So some practice points for topical therapy. Topical steroids are the first line therapy in mild to moderate psoriasis. The combination of calcipotriol and steroids are safe and effective if used judiciously. Overlap of napkin psoriasis and diaper dermatitis, you should investigate and rule out monilial infection and allergic contact dermatitis, then treat for psoriasis. Rotational therapy with vitamin D analogs, topical calcineurin inhibitors and emollients can be considered. The facial, inverse and napkin psoriasis, those areas, calcineurin inhibitors and emollients like the tacrolimus, pimecrolimus and topical emollients can be used, and avoid topical steroids in those cases. For the palms and soles, potent topical corticosteroids and keratolytics are good option. And for today's date, tofacitinib in gel and ointment forms currently available is a very good and safe option even in cases of pediatric psoriasis. Indications of systemic psoriasis. If it is a severe psoriasis, rapidly evolving, unstable and relapsing disease, some resistant areas we do not respond to topical therapy, and if it is a severe type of pustular erythrodermic type, affection of severe DLQI. So these are the drugs which are used, the retinoids, methotrexate, cyclosporine, and we do have phototherapy and biologics in the treatment armamentarium. Recent advances, biologics not to be discussed in this forum, and the JAK-STAT inhibitors recently in India, this is available as tofacitinib molecule, which is quite a safe as compared to other immunosuppressives. Few of my patients experience like oral cyclosporine in this particular erythrodermic, moderate to severe psoriasis with oral cyclosporine 3.5 milligram per kg body weight. The patient almost responded after 5 months, and apart from the hypertrichosis due to cyclosporine, no other side effects was seen. Again, this child of erythrodermic psoriasis was wrongly introduced with injectable steroids, and finally the patient was admitted under us, and we treated the infant with cyclosporine, and then until today's date also the child is doing well. This is the response to phototherapy, a narrow band UVB phototherapy, which is a pre-treatment and post-treatment after 14 sittings. So a very safe and efficacious treatment modality of any child beyond 6 years. You can refer the patient for phototherapy wherever the institutional facility is available. This patient of generalized pustular psoriasis, the 9-year-old female child, she was not responding to any other treatment like even acetatin, she did not respond. But she responded to a higher dose of cyclosporine. And after a few months, like 3 months, there was complete resolution of the lesions. And there is a remission till date. There are a few flare-ups on and off, but other than that, cyclosporine is a wonder drug for erythrodermic and other severe type of psoriasis. Oral methotrexate works very well. So 7.5 milligram per kg per week can be an initial dose, and the PASI 90 can be achieved at around 6 weeks. Now this patient of scalp psoriasis, we gave apremilast 30 milligram OD along with topical tacrolimus for 6 weeks, and PASI 90 was achieved within 6 weeks period. However, there was a relapse. Every time we reduce down the dose, there is relapse, but the patient actually is happy that okay with the drug which needs no monitoring, and she was quite easygoing with apremilast orally. We have to maintain her sometimes with topical therapy and sometimes with oral. Acetatin, again a very good oral retinoid, works wonders in other congenital ichthyosis. Even in case of pediatric psoriasis, 0.5 milligram per kg body weight we have introduced in this patient, and PASI 75 was achieved after 4 weeks. This 15-year-old, even the lesions were not very florid. Just 1 minute. So this child didn't respond to any conventional therapy, neither with methotrexate nor with cyclosporine nor with apremilast. None of the drugs responded. So we had to give her a biologic injection, that is TNF-alpha inhibitor adalimumab, and with 40 milligrams doses, 10 doses 2 weeks apart. This is what was the response, and she was very happy that she could wear smaller skirts and smaller dresses. That was the main intention why she was happy, that doctor, you have treated me so I could wear some Western clothes. So this was one of the patients. Recently we gave oral tofacitinib 5 milligram OD with topical vitamin D analogs. And post 3 months treatment, the response was very encouraging with some monitoring of bloods. Definitely a JAK-STAT inhibitor requires some oral monitoring of some blood test and also routine, all the routine tests, and we need to know the triple H status and the tubercular status. However, this molecule is extremely promising in many patients. So with this therapy, the patient responded really well. So to sum up, key points in the management: poor adherence in therapy, triggering factors and unhealthy eating habits and peer pressure, psychotherapy, parental counseling, and lifestyle modification is required. And we should give a special consideration for the for the girls of the childbearing potential and live vaccination. These are the two things which one has to be addressed. Incidence of gutted psoriasis, if frequent, then look for infective focus and necessitates the antibiotic therapy. And methotrexate, acitretin, cyclosporin, narrowband UVB all have proven their efficacy, can be used safely for months. With psoriatic arthritis, the JAK-STAT inhibitors are approved. Thank you very much for your patient hearing, and my acknowledges to my PG students, Dr. Aditya and Dr. Ananya, who are actually helping me out with all the psoriasis patients, and we are doing good research work based on their inputs and their support. And my gratitude to Sandipan sir. Thank you.